So today we are going to talk about elbow and forearm. So elbow and forearm is made up of the distal portion of the humerus and the proximal portions of the radius and ulna. So these are the portions we will focus on when we talk about radiographs. So let's start. So elbow x-ray view. So elbow, like I said, is the distal portion of humerus, the bone of the arm, and the two bones of the forearm, which are radius and ulna. The proximal portions of radius and ulna and the distal portions of the humerus bone is what we're going to be focusing on in context of the elbow joint and the radiographs. So the first view, the x-ray view that we take is the AP. So this is the anatomical position. So if I put my hand like this, so this is the AP view. So if my hand is placed like this and the x-ray tube is perpendicular to this orientation of my arm, then it will give us an AP view or the anterior posterior view. So this is the lateral portion, lateral view. So what we do for this view is we ask the individual or the patient or the person who is to be x-rayed to place their hand like this. So this is a mid-prone or mid-supination position, and this is the placement of the arm and forearm, and the direction of the x-rays is again perpendicular to this placement or this orientation. So if the x-rays are falling from this direction and this is where the cassette is placed, then this will make a lateral view of the elbow joint. Then we have an oblique view. So the placement will be same, mid pronation of the forearm, and the flexed position of the humerus and or the elbow joint is flexed, but the orientation of the x-rays will be 45 degrees. So for lateral, it was this direction for the x-rays, but for the oblique lateral view, the x-ray position will be somewhat like this. So this will be the position. So let's do it here. So this will be the position of the 45 degrees angle. So this will be the position for this oblique lateral view. So this is the oblique lateral view in which the direction of x-rays has changed, but the position of the individual's or the participant's hand is the same. It's mid-prone and slightly, or actually 90-degree flexed. And this is when the orientation of the arm is perpendicular to the direction of x-rays, not perpendicular in this view. And here it's an AP view, which is like I explained, the x-rays are perpendicular in the lateral and the AP view, but they are at a 45-degree angle when we're talking about the oblique view. So these three are the views that we use for the visualization of the elbow joint. Now we'll see the specific structures that we have to look at in a radiograph. So this is an AP view, like I explained. So this is the placement of the hand, and the x-rays are falling perpendicular to this orientation of the arm and the forearm. So this is the olecranon process of ulna. This is the trochlea of humerus. This is the coronoid process of the ulna. Again, this is the radial head and the capitulum. So this is the medial portion of humerus. This is the lateral portion. This is the medial epicondyle, and this is the lateral epicondyle. And ulna is obviously present in the medial, present medially, and radius is present laterally when we are talking about the anatomical position of the hand, in which the thumb is pointing outward. So the radius is said to be memorized, or people memorize it, that the radius is towards the thumb of the hand. So this is the placement, and radius is laterally, ulna is medially, and the humerus is, well, this is the humerus, one bone in the arm region. So these are the specific anatomical positions of the different bony structures which appear on radiograph. This is a normal radiograph. So this is how the different structures appear. Now we're going to talk about dislocation. So in the introduction, I said that we name the dislocation in a way that we call it posterior or anterior based on the position of the radius and ulna, specifically the ulna. So this is the olecranon process of the ulna, and this is the trochlear notch, right? So the trochlear notch, and this is the trochlea and capitulum of the humerus. So this is placed posteriorly, so we will call this a posterior elbow dislocation. Then we have this anterior because the ulna and subsequently the radius has moved anteriorly, so we call it anterior dislocation. Then this is the divergent dislocation, in which both ulna and radius have moved apart from one another, and also the notch here is empty actually. So this is very rare, this dislocation, but as a consequence of this dislocation, there is absolutely no movement. The person cannot flex the arm fully, and the extension is very much painful. So this is very rare. So then this is the lateral. So if both the ulna and radius have moved laterally, so lateral is outside of this this direction. So if they move that way, then it's called lateral. And then we have medial. When they move towards the body, it's medial. So this is medial and lateral. So this is all about how dislocations can present. Mostly the common elbow dislocation is posterior dislocation. Now we will see how elbow dislocations appear on radiographs. So this is the posterior dislocation, like we discussed in the previous slide as well. So this is when the ulna has moved posteriorly. So this is called the posterior dislocation of elbow joint or ulna, and this is how it presents on a radiograph. This again is an AP view in which we can see that the ulna has moved posteriorly. Now we will talk about Masson classification of radial head fractures. So radius is the lateral bone, and how its fractures present, we will talk about this in this section. So first this is the radial head, and if there is a fracture of this through and through fracture of the head of radius in a way that it is starting from the epiphysis and is going towards the neck of the bone or the metaphysis. So this is the first type. Then we have type 2. So in type 1, there is a fracture, but there is no displacement of the fragment. So in type 2, there is a displacement of the fragment. And then we have type 3, which is a comminuted fracture in which there is also displacement of the fragments. So this is the type 3. And in type 4, there is a single fracture of which is through and through from the epiphysis and metaphysis, but it is a single comparatively larger portion which is pulled by some tendon away from the fracture site. So here we have a normal radiograph of an AP view. We can see the olecranon process, the trochlea, the capitulum, the medial side of the humerus, which we call the medial epicondyle and the lateral epicondyle. This is the radius bone, and this is ulna. So this is a normal radiograph. Everything here seems normal. So now this is obviously a fracture or an abnormal radiograph as we compare it here. So it's obvious that there is this abnormality here. So what is it? It's a displaced fragment of the radial head. So when the radial head is displaced in one fragment and it is relatively far away from the radial head, we call it type 4 Masson fracture, right? So this is type 4 Masson fracture, as we discussed previously, and it is displaced relatively away from the a larger distance from the original fracture site. So this is a type 4 Masson fracture, and this is the normal radiograph. So this is a fracture classification which is very important and is missed most of the times, and people consider it an isolated fracture, but later on the similar or this same patient presents with a much severe pain and a relatively reduced movement pattern, and so it's very important to know Monteggia fractures in young individuals, because basically what it is it's a fracture of the ulna, but also together with a dislocation of the radial radius. So people normally just because of its presentation on day one or in a few hours or in acute condition, it appears on the radiograph as a isolated ulnar fracture. But in the subsequent days, it is visible that there is also a radial dislocation. So let's see into it. So this is type 2A of the Monteggia fracture classification. So we classify Monteggia fractures on the basis of there is always going to be a complete through and through fracture. The olecranon process will not be in continuation or with the rest of the ulna. So it will be completely separate from the mother ulna bone, and the radius is always going to be displaced. It might not look like a displacement in acute conditions, but if you look closely, there is always signs. So this is the olecranon complete fracture here, and also fragments. So in all of the Monteggia fractures, there are fragments of bone, but the more the bone involvement, that is how you grade it into A, B, C. So this is 2A. These are the severe types of Monteggia fractures that we're talking about here. So this is a type 2A in which there is fragments, but the bone involvement is relatively only the proximal portion of ulna is involved here. So as we move to 2B, as we can see, the fracture site has relatively become more towards the distal portion, so it's moved distally. And in type 2C, it has moved past. It is actually crossed the neck of the bone ulna and has actually entered the shaft area. So this is how we differentiate between 2A, B, and C in Monteggia fractures. And again, this is moving away from this proximal portion, moving distally, and that's how we name it ABCD and 2ABCD, and this is comminuted as well, but there are relatively bigger fragments of bone. So here the fragments were relatively small, so this is how we classify Monteggia fractures, but basically Monteggia fractures can be just without any fragments. It can just be this one line, and the olecranon process will always be separate from the ulna as a consequence of Monteggia fracture to be classified as a Monteggia fracture, but people miss it and they consider it an isolated fracture of the ulna, but Monteggia fractures are specific that they are with radial dislocation as well. So these are very easily missed, and these cases, there are numerous cases in which the patient presents some weeks later, and we're also going to discuss a similar case. So the patient presents a few weeks later, and they say that they have limited ROM, ROM as in range of motion. They cannot move their arm, and the pain is severer than it was in the acute condition. So this is basically the Monteggia fracture. This is actually a day 1 injury of a 3-year-old child who falls from the sofa, and we or the person who looked at this radiograph actually thought it was just an isolated ulnar fracture, which is very common, and people mistake it for isolated fracture because they don't really understand if and not a lot of attention is paid to the radius here, which actually looks pretty normal as it's in line with this ossification center. So this fracture is relatively prominent, so people actually mistake it for an isolated fracture, which we have discussed. So this is day 1 injury in which there is this fracture. And obviously the POP was applied to this kid, 3-year-old kid, and this is actually 5 weeks after the injury. So what happens is, as we can see, this bone in 5 years has become ossified, has become relatively, the density has increased. So in 5 weeks, this is not normal growth of the bone. So this is abnormal or hypergrowth. So this is hypergrowth of the bone in 5 weeks' time. And you can see here the radius is now prominent. It is now prominent that the radius is displaced because it is no longer in a continuous, the center is no longer in a continuous line with the ossification center here, right, as it was here. So it was actually aligned with it, but here we can see it's not. So it was a missed displacement or dislocation of the radius, which was missed earlier, but it was it shouldn't have been, because now the patient is in severe pain, and it's now become a chronic injury because it's been 5 weeks and nothing has been done for this dislocation. Now we will talk about bicep tears. So bicep attaches to the radial tuberosity on the radius. So we will look how it appears on imaging modalities. Okay, so this is actually an endo button repair. So this has been repaired. The bicep tendon that was torn has been repaired. So what we do is we drill into the bone. So the bone is drilled here, and obviously because this is the radial tuberosity, and the bicep tendon comes here and attaches at this site. If this is ruptured and is in this and is present here, so let's just imagine for a bit. So the bicep tendon is ruptured and is not attached to this site here and is present somewhere here. So what we do is we drill the bone. We incision here, and we come to this bone, we drill it, we drill a hole, which is visible here actually. So we drill a hole in this bone. This is the radius bone. This is a lateral view. So we have drilled a hole here, and what we do is we tie the tendon, the bicep tendon, the distal segment or the distal aspect of the bicep tendon is tied with a thread, and what we do is we make the tendon pass through this hole that we have drilled, and then we add some material to actually just cover the remaining spaces, and this is what we attach to the other end of the bicep tendon. So the distal aspect is attached to this endo button, which can pass. If it is in vertical orientation, it can pass through this hole, right? So let's just take it into imagination. So this is in vertical position, and we attach this. Okay, so this is the, let's just suppose this is the ruptured tendon here. So we attach it to this endo button, And then in a vertical orientation, we insert it in this hole that we have drilled, and then we change the orientation of this endo button into a horizontal orientation. So now it is horizontal, and this hole that we drilled is not big enough for this to actually move in a horizontal position out of this radial bone. So now it is stuck. So what we have done is we have actually repaired the bicep tendon, and now it is inserted inside the radius bone. So that is how you repair the bicep tear. This is one of the ways. It is very effective because the post-op complications are relatively minute or negligible. So this is a process of distal bicep tear repair, which is, and this is how the bicep repair will appear on a radiograph or an X-ray. Okay, so this is a displacement or dislocation of both the ulna and the radius. So the radius is displaced in an oblique and posterior direction, whereas the ulna has displaced in a posterior and superior direction. So this is a displacement, and if you think of this biomechanically, then it is not possible for this individual to extend their arm, obviously, because these two bones will actually hit the humerus here, so the extension is impossible, and this person cannot be asked to actually place their arm like this or in orientations for a normal X-ray view. So this is actually a relatively this sort of orientation of the patient, and this is the only possible way that the patient can place their arm on the bucky. They can't extend their arm. They can't place it like this or in mid-prone position. It will be impossible if you think biomechanically. So this is double dislocation or double displacement of both the forearm bones. So now we're going to talk about pediatric supracondylar fracture. So what happens in supracondylar fracture is, before going into the radiographs, let's just take a little bit of time to discuss some things. So we will talk later on as well about the fat pads. So supracondylar fractures in pediatrics can be diagnosed only if there is a presence of a posterior fat pad. So which is different for an adult. So if a pediatric or a child is x-rayed and there is a prominent posterior fat pad, then we suspect a supracondylar fracture. So supracondylar fracture is actually a fracture of the humerus bone. So the distal portion of the humerus bone, supracondylar fracture, is actually above the medial and the lateral condyles. It is the portion of the humerus which is most vulnerable. So the supracondylar fracture is common in young individuals, and the criteria for diagnosis is different. But for posterior fat pad is a very commonly taken a thing that actually indicates that the presence of a pediatric supracondylar fracture. So we will discuss fat pad later as well. So I will repeat this and it'll be clear in that segment. So here in supracondylar fracture, we're going to discuss the AP view actually. So fat pads are visible only when you take the lateral view. So if you're taking the AP view, then fat pads are not going to be visible. So this is an AP view, and the supracondylar fracture can be diagnosed from both the views, the lateral and the AP view. So when we're talking about the AP view, this is a child's bone. As we can see, there are ossification centers and the entire bone has not ossified yet. So this is the fracture here and here. So these are the medial and lateral epicondyles, right? So supracondylar means above the condyle. So this area is vulnerable, and there is this fracture here and here. So this is known as supracondylar fracture. Supracondylar fractures are common in pediatric population. Let's just again revise what we said. So pediatric supracondylar fractures, when we're taking the lateral view, with not this one, this is the AP view. When we're talking about the lateral view, if there is a posterior fat pad, it is indicative of a supracondylar fracture in young children or in the younger population. So an adult, if presents with a abnormally prominent posterior fat pad, we suspect radial head fracture. So again, radial head fracture in adults and supracondylar fracture in children if there is a prominent fat pad. But to actually confirm the diagnosis, an AP can be asked, and in AP view, the supracondylar fracture will be visible as well. So both views can be used either isolated or together. So now let's talk about fat pad, which we have discussed a little bit. So now we're going to actually go directly to the X-ray and see how they appear. So like I said, fat pads are visualized using the lateral view. So in the lateral view, so this is the lateral view, and if we take this lateral view, then we can actually visualize the fat pad. So this is an interior fat pad, and this is a posterior fat pad. So interior fat pads are almost always visible in an adult X-ray. So this is an adult X-ray. The entire ulna bone is ossified. There is obvious, the margins are complete. So this is an adult bone. So this is the posterior fat pad and the anterior fat pad. So the supracondylar region is this one. So if this were in a child's X-ray, which it is not. So this is an adult X-ray, but if it were a child X-ray and it was present with a posterior fat pad or a visual posterior fat pad, then we would have suspected a supracondylar fracture. But if the posterior fat pad is visible or abnormally visible on an X-ray of an adult, then we suspect a radial head fracture. So this is a little bit about the fat pads. The anterior is always present, mostly always present, and the posterior fat pad is only visible if there is some fracture of the supracondylar in the supracondylar or the radial head region. Now we will talk about the olecranon fracture or the displaced olecranon fracture. Olecranon process is actually a process of the ulna. The proximal ulna portion is known as olecranon process, which we actually visualized on the X-ray, and let's do it again. So this portion right here is known as the olecranon, right? And if it is fractured and displaced, this is a displaced olecranon fracture. What this will do is it will actually impinge here and probably cause a supracondylar fracture as well if a patient falls on an outstretched hand in a way that this is pressed towards. It is actually compressed and the fall is on an outreached hand, then two fractures can be suspected. So one is displaced olecranon fracture, and the other one is the supracondylar fracture, the humerus, so ulnar humerus. Now we have torn distal bicep tendon. We discussed the repair of the tendon. Now we will visualize how it is displaced and visible on the MRI. So this is an MRI. This will go on to attach on the radius bone. So this is the retracted portion of the proximal tendon, and this is the retracted portion of the distal tendon. So there is a huge gap, and this is how the tendon rupture appears on an MRI. So now we will move towards the chronic conditions of the elbow. So what can be the chronic conditions? Chronic conditions can be, like we discussed in the introductory section. So it's actually the biomechanical wear and tear, or the mechanical wear and tear, whatever you want to call it. So it's improper use or excessive use of the joints or the limbs. It can be due to some autoimmune conditions like RA. RA is an autoimmune disease. It can be due to excessive use of muscles, like, for example, golfers' elbow and tennis elbow. Tennis elbow is the lateral epicondylitis, and golfer's elbow is actually medial epicondylitis. We'll see how they appear on MRI and X-rays. So first condition that we have is degenerative joint disease, also known as osteoarthritis. So that is a chronic condition because it appears, or it is a progressive condition, which actually it takes a long period of time for it to take place or occur in a joint, like we discussed in other lectures as well. So what happens in degenerative joint disease is there is increase in the osteal activity, in the periosteal activity in the margins of the bone, also known as sclerosis. There is joint space reduction, which is consequence of cartilage degeneration. We also talked about osteophyte formation. So all of these changes are collectively known as degenerative joint disease or osteoarthritis. So then we have rheumatoid arthritis, which is actually an autoimmune disease, and it results in a deformity of the bones, and also a very debilitating disease. So then we have ligament tears and tendonitis. We will discuss how, so first let's establish the fact that all the flexor tendons, they are attached to the medial epicondylitis or the medial epicondyle. So epicondylitis, so medial epicondylitis will result in the flexor compartment to be impaired, right? So the lateral epicondyle, any abnormality there results in lateral epicondylitis, which is actually an attachment site for all the extensor muscles of the forearm. So we will also talk about that in detail as well. Then we, like I said, the ligaments are attached, the collateral ligament of the ulna and radius, so that we will discuss in the ligament tears. And the tendonitis is obviously the medial and lateral epicondylitis is similar to the tendonitis because these tendons attach to the medial and lateral epicondyles. So we will. This is all interrelated, and we'll discuss this in this chronic conditions of elbow section of the lecture. So let's start with medial and lateral epicondylitis. So this is actually a STEER image. The last MRI image that came, it was also a STEER image. So what a STEER image is, it's a short T1 inversion sequence. So this is, in T1 there is hyper intense fat, right? So to nullify the effect of fat, or to not visualize the fat when the fat visualization is not required, we ask for a STEER MRI. So this is a coronal view. Coronal is the frontal. So the axial view is a cross-sectional view, and the frontal view is also called a coronal view. So this is a coronal STEER MRI. So this is the medial epicondyle here, and this is the attachment site. So remember, On the medial aspect, all of the flexor muscles will attach. On the lateral aspect or of the humerus or the lateral epicondyle, all the extensor muscles will attach. So if there is a problem here on the medial aspect of humerus or the medial epicondyle is involved, always suspect that there is a problem with the flexor muscles. So this is the medial side, and this is a tendon rupture here. This here is also a tendon rupture visible here. So these two are showing the medial aspect of the elbow to be involved. This is the rupture here and here. So now we're going to talk about the tiers of common extensor tendons. Medial epicondyle, this is the extensor or the lateral epicondyle. So extensors attached to the lateral epicondyle, all of this is related. The medial is the attachment site for the flexors. The lateral epicondyle is the attachment site for the extensors. So the extensors attached to this lateral epicondyle, and these are the tendons that are seen to be ruptured here. So this is the axial view. So this here is the attachment site of the extensor tendons. This is the lateral epicondyle. Now we're going to talk about collateral ligament. The ulnar, there are ulnar collateral ligament, also known as the internal collateral ligament. There is also an external collateral ligament or the radial collateral ligament. So here we're talking about the ulnar collateral ligament. So this is the ulna bone, and here is where the collateral ligament is present. It attaches to the ulna portion of the radius as well, and then the medial epicondyle. This is the attachment portion of the of the medial collateral ligament or the internal collateral ligament, also known as ulnar collateral ligament. So the rupture will result in instability. So what happens with ligament ruptures is we have an unstable joint. So unstable joints result in the wear and tear of the joint surfaces, which results in degeneration within the joint. So these can be missed initially, and that is why we add them in the chronic conditions. So the tear can be acute, but it can be missed, and due to which there are many degenerative changes. That is why we call it a chronic condition. So this is the a little bit about the ulnar collateral ligament. Again, this is a stereo image of the MRI. This is again a coronal or a frontal view. Now we have avulsion fractures. We discussed avulsion fractures before as well. So what happens in avulsion fractures is that the bone fragment is fractured, and because of the pull of the muscle and tendon, it is moved away from the fracture site. So avulsion fracture here we're going to discuss in reference to or in context of medial epicondyle. So medial epicondyle, I will repeat again, this is very important to remember. The medial epicondyle is actually an attachment site of all the flexor muscles. So when the flexor muscles are going to pull the fragment of the fracture away from the humerus, because epicondyles are part of the humerus bone, so they will move it away from the humerus. So that is what we call a medial epicondyle avulsion fracture. Very rare, but is seen rarely. So this is an avulsion fracture of the medial epicondyle. This is the medial epicondyle, the attachment site of all the flexor muscles of the forearm. Then we have, again, ligament. Very important to remember, if there is ligament tear, it will result in instability of the joint. Instability will lead to many degenerative changes within the joint. So here we're going to talk about the torn collateral ligament and see how they appear on MRI. So this is a torn collateral ligament here. Again, a steer image. This is a coronal view. This is the ulna bone, the radius, and the trochlear and capitulum here, and the humerus. So this is the torn collateral ligament, which is present from here and here. So this is torn because of this dark portion here. So that is how you visualize it on an MRI. So to actually diagnose things on MRI and X-ray, you have to have a detailed history. Otherwise, looking at an image will not give you anything. So always the history will play a part. Different views, different images, different imaging modalities will play their part, and other tests as well. So that is how you reach to a diagnosis when you're going to take into the account all of the different views, the entire history, other medical tests, and then you're going to reach a diagnosis. Otherwise, it's not easy to diagnose on MRI without knowing the history, without knowing the entire case, without knowing the gender or the age, because it is different. The fracture classifications are different for genders or age groups. So after this entire talk on the history and everything that is required for a proper diagnosis, let's just also talk a little bit about the tennis and golfer's elbow, because it's an important topic. So what happens in tennis elbow is that there is excessive load on this lateral aspect of the elbow while playing tennis. Like, you're hitting the shot, and so the entire, when the ball is hitting the racket, the stress is going to be on the lateral aspect. So continuous stress over a long period of time, because you are playing the sport over a long period of time. So what it does is continuous stress actually impairs, or there are a couple of it can disease the or impair the proper functioning of this of all these tendons which attach to the lateral aspect, which are the extensor tendons. So because they are they are again and again in constant stress because of playing games like tennis. So that is why lateral epicondylitis is also called tennis elbow. And then we have medial epicondylitis, which is called golfer's elbow. And the reason why that is because when we're playing golf, when the ball is going to be hit to that the stick of the golf that we use, then what's going to happen is that the stress is going to be placed on this medial aspect of, because this is how you play, right? So the medial aspect is going to be under constant stress. So what will happen is the tendons which are attached to the medial aspect of the elbow joint, or the humerus, will be affected. And what are the group of muscles that are attached to the medial side are the flexor muscles. So flexor muscles will be impaired when there is medial epicondylitis. So that is the difference, and why we call them golfer and tennis elbow. So that is it for the chronic conditions. And with that, we have reached the end of our lecture on forearm and elbow. We talked about acute conditions and chronic conditions. In acute conditions, we talked about fractures and different fracture classification. We talked about dislocations. We saw how they appear on radiographs. We saw how we looked into what the normal views of the elbow joint are. Then we moved towards the chronic conditions, we didn't talk a lot about the osteoarthritis or rheumatoid arthritis because we have covered that up in the previous lectures as well. So we jumped right to the medial and lateral epicondylitis. We talked about torn ligaments. We also talked about how history is very important to diagnose with the help of radiological imaging modalities. So that is the end of the lecture. I hope you enjoyed it, and to watch more videos, please visit sqadia.com. There are multiple videos on numerous medical related topics, and that is it for today. Thank you for watching.